In this video, I am going to break down shoulder anatomy and biomechanics, and I'm hoping to provide you with a framework that allows you to better understand the shoulder complex. And so, I mean, the word has complex in it, but I don't think the shoulder needs to be that complicated. And the way I'm going to break this down is into passive stabilizing structures and active stabilizing structures. And you can see those on the screen right now. And before we get into it, if you like the format of this video, please like the video or make a comment, or if you want to see a similar breakdown of other diagnoses or other anatomical things, post it in the comments because that's how I can start making more of this. I'll use the data from these videos to hopefully make other similar videos like it. So before we get started, there's a few considerations that I want you to think about. And we're going to talk about the shoulder anatomy, but we're also going to talk about how the shoulder is related to everything else. So first thing, I want you to jut your head forward, go into a real forward head posture position, and then try to raise your arms up overhead. As I do that, when I get to about 160 degrees of shoulder flexion, I really feel my upper trap start to kick in and hold that movement. And the reason is because the position of the cervical spine, so if I bring my head back over the top of my body, then I can go through that full range and I don't feel these upper traps being put in that actively insufficient position. So the position of the cervical spine is going to directly relate to the position of the function of the shoulder. The other thing is I want you to, if you change the position of your middle back by rounding, slouching a whole bunch, and then raise up, you're going to see a very similar thing happen where you can't achieve full shoulder range of motion. And that's because the position of your core musculature and the position of the thoracic spine really drives how the shoulder anatomy can function and then what the shoulder biomechanics look like. So even though we're talking about the shoulder here, we have to think about the regional anatomy as interplays of what happens with the shoulder and then also how the shoulder gets injured and things like that. So when we dive into shoulder anatomy and biomechanics, we're going to start here on the left side of the screen where you can see the passive stability, and that's going to be our skeletal and soft tissue structures. And yes, you could say that the musculature is a type of soft tissue, but that's going to be active stability. And I just want, for simplicity's sake, we're breaking it down into passive versus active. So our skeletal system for the shoulder complex, the scapula drives our shoulder function overall. And the reason is we have our clavicle here, the SC joint is most medial. You follow the clavicle out to the AC joint where it meets the scapula. On the opposite side of that, we have the humerus, which comes up and matches the glenoid. So both the clavicle and the humerus match and meet the scapula in the middle. And so the position and the function of the scapula is going to really determine the overall function of the shoulder complex. So we're going to get more into these individually, but when you can understand the layers of it, the pieces of it, then we can put together the whole picture with a lot more simplicity. So we have our skeletal structure. On the soft tissue side of it, we have ligaments, and those ligaments are going to be for both where the clavicle helps provide passive stability with the scapula, and then also the glenohumeral ligaments, which is where the ligaments that connect the humerus to the scapula. So we have our bony skeletal structure, and then we have soft tissue such as ligaments, the joint capsule, which provides a layer of stability, our labrum, which provides a suctioning effect and also further stability for the shoulder. And then lastly, bursae, which act as spacers in the joint to provide proper mechanical advantage for the muscular system. And that's going to be our passive stability. And then on the right side, if we can break down the musculature into two distinct groups, one being our rotator cuff musculature, and then two being our scapular musculature, then we can see how those interplay together to allow for full range of motion, proper strength in various positions. If you can mentally separate each of these four into different buckets, you're going to be able to start understanding the layers of how the tissues must work together, and then how, if let's say the scapular muscles aren't working, how that might put more stress on the soft tissue. You'll also see that from using this framework, that position and posture and body mechanics and biomechanics are all very important for overall efficiency of the shoulder joint. Now, someone might say, well, I can be in a really slouched position and raise my arm up with a weight in my hand and I don't get pain in the labrum. That is true. But when you put the body in a forward rounded position, we're really changing the position of the glenohumeral joint, which puts an inherent pressure or instability into the system. So the stronger I am, or the more biomechanically sound I am, the easier, the less strain you're putting into the system, which you're going to get more output on the back end. I always say that input directs output. And if you can learn how to best position the body for the easiest input, then you're going to get a lot more output on the back end. So next, we're going to translate over into using the Essential Anatomy app. And I want to give credit to Essential Anatomy. It's an amazing app that I share with several of my clients. I also use it for educational purposes. And it's such a valuable tool for understanding the layers of anatomy and how we're really built. So we're going to transfer over to that. I'm going to stop sharing and then go to another screen real quick. Now, we're looking at the left shoulder here. So if I zoom out, you can see we have our clavicle, SC joint, AC joint, humerus, and then on the back side, we have the scapula. Now, currently on this diagram, the connective tissue is still on there. So I'm going to pull back the layers. Here's the clavicle. And as I am looking at the inherent stability of these various things, you can see that the head of the humerus is a lot bigger than the glenoid fossa, which means that the joint is going to be built for mobility. We need a lot of motion in the shoulder, and that's why it's the most mobile joint in the body. If you look at the connection of the SC joint here, there is not a ton of stability built into the SC joint either. It's only a small surface area matches where the sternum hits the clavicle. A personal experience of mine, I had venous thoracic outlet syndrome 12 years ago or so. And if you look at the articulation of the first rib and the clavicle, and if I put the connective tissue back on there, you can see how this area of the body articulates with itself. And so when they took out my first rib here, I'm going to hide the first rib, and then I'm going to remove the connective tissue. You can see how this joint loses even more stability right at the SC joint. So now if I'm doing pull-up movements or if I'm doing different pressing motions, I've lost some of the regional stability and I can feel more play at that joint, which means my scapular muscles and the muscles that run from my clavicle up to my neck, they need to be stronger and they need to be in the right position so that SC joint doesn't take on too much strain. Now, because I live a very active life, I have built up kind of a bony arthritic changes at that SC joint. And as a result of that, if you feel side to side here, you can feel a raise in the clavicle, and I can still feel extra movement there, but I've built a lot of strength around that area where my body can adapt and accommodate really without any pain. Now, if I spend too much time on the computer, if I'm in a slouched position for too long, because the constraints of the system are different, then that's where I'll start to feel some relative neural symptoms down my arm, which actually manifest as a radial nerve tension right through my elbow. So we have our clavicle with the SC joint working its way over to the AC joint. Then we have the humerus, which meets at the glenohumeral joint. And both of those come together, like I said earlier, with the function of the scapula. Now, as we add a layer onto this, so I'm going to put the connective tissue back on because that's the next deepest layer. You can see that we have ligaments that run. So we have our trapezoid ligament, and then we'll have our conoid ligament. One second. Deeper in here. Those are passive stabilizers that guide the function of what happens between the clavicle and the scapula. I don't even think knowing the names of those structures is extremely important. The one thing that I would say, if we go back to the other graph, you can see that all structures in the body are going to have, minus skeletal tissue, which doesn't really have a neural input by itself, all the soft tissue and all the musculature has some sort of sensory input that goes back to our nervous system. So if you look at the other chart again, and I'll have it up towards the end, but you can see how the conoid and the trapezoid ligament, if you look at their innervation, they have sensory input that goes back to C3, C4. If we look at our glenohumeral ligaments, so the inferior glenohumeral ligament, if I isolate that structure, the middle glenohumeral ligament, and then the superior glenohumeral ligament, each one of those goes back to C5, C6. And that's important because if someone is having any dysfunction at C5, C6, or if the glenohumeral ligaments are taking on strain, and this goes for the bursa, some of the bursa in the shoulder, and it also goes for the labrum and joint capsule because those go back through C5, C6 too. And what that means is that there's sensory peripheral nerves that connect through the brachial plexus back to C5, C6. And so if we're seeing problems peripherally through those structures, we're going to feel that somewhat centrally back at the spinal cord level. And the interplay of what happens at the nerve root level and then what happens at the peripheral tissue level, there's constant feedback between those two. And that's where input functions for what the eventual output will be, and the output relies on the input. So whenever there's something that's happening with labral tissue, with other soft tissue like the ligaments, we need to be looking at what's happening at the spinal cord level too, at the appropriate nerve root, because most likely as the peripheral tissue is feeling that strain, somewhere more centrally at the spinal nerve root level is also going to be feeling or having a relationship with that pain. And that goes on a very deep reflexive type of level. And that's how pain works. It's a reflexive response. So oftentimes pain happens before we have that voluntary cognition of what's going on. So we've talked about the conoid and the trapezoid ligament. You can see the inferior middle and superior glenohumeral ligaments. Those provide passive stability, meaning they don't really guide or control. They guide stability of the motion, but they don't have any function to dictate the motion. Now, if I am in a slouched posture, what that does is it closes off the space between my clavicle and then my pec musculature. So that narrowing of that space, if I'm there for a long time, the collagen that is the root of this soft tissue is going to be held in a slightly tighter position. So then what that means is if I'm there for a long, long time, we'll start to see stiffening of those ligaments in those positions. And that is mechanotransduction. That's how the body is going to always rely on the mechanical input that it's given. So if I'm here a lot, I'm going to see relative shortening or tightening of that soft tissue as well as the active tissue. So the position that you're in is going to dictate how much inherent stability is built into that specific posture or that specific position. But the main point of this is you need to know that these things are going to be things that you can change by changing your posture, but we're not going to, you strengthen these through changing the mechanical input to it. And if you're not giving your body a wide variety of mechanical input, meaning if you're always stuck in one position, then it's going to be those ligaments and the other passive stabilizers are going to start getting stronger or holding tension in those positions. So conoid, trapezoid, here we have our coracoacromial ligament. And so what that does is provide some stability. Well, and this one's kind of funny because if we isolate it, you can see it just runs from the scapula to a different part of the scapula. So because the shoulder has so much motion, we have all of these passive stabilizers which help control that function. All right, so I'm going to stop the share on this for just a second, and then we're going to go back to our diagram again. Now we've talked about the humerus, which is the long bone. We've talked a little bit about the scapula, and we've talked about the clavicle. The clavicle, from a biomechanical standpoint, needs to help with rotation and getting the shoulder and the scapula to tip back into that position. So if those ligaments on the front have been stiffened in a shortened position, the ability for the arm to rotate the scapula relatively backwards to get the arm overhead is going to feel that stiffness. Now, because we're such a dynamic structure, the whole body is so dynamic, this is not happening in isolation. The pectoral muscles, the bicep tendon, the coracobrachialis, all of those are shortening in a very similar response. So we have the humerus, the clavicle, the scapula. It's the flat bone that makes up the scapulothoracic joint as it articulates or sort of floats along the backside of the body. One of the coolest things about the scapula is that the relative weight of the scapula is extremely light. Now, there's tons of muscles that need to work across there, but it's this flat, lightweight bone that, because of its type of bone that makes it up, is extremely strong to withstand all those stresses. It's extremely strong despite not having that much weight to it. And that's just sort of some of the magic of the human body. So the skeletal structure, it doesn't really have a ton of neural input, but we get all that nervous system input from the first layer, which is this soft tissue that surrounds the area. So we've talked about the skeletal structures, we've talked about the ligaments, and next we're gonna kind of go over the layers of joint capsule, labrum, and then the bursa. So I'm gonna switch back over to the other screen. I'm gonna stop the share here and going back to the Essential Anatomy app. And first thing you can see on the bursa, we have a subscapular bursa. Laterally, we have a subdeltoid bursa. Posteriorly, we have an infraspinatus bursa, and then we have our subacromial bursa. Those four, well, actually, even up here, we have a subcutaneous acromial bursa, but these are all fluid-filled sacs that act as spacers, essentially, so that the other musculature, they create room, so there's not so much friction going across the musculature. And those 5 bursa, they can get inflamed if there's too much mechanical stress or too much mechanical friction going across them. But ideally, we're not seeing those take on too much stress if things are working well, if the muscles are strong and they're supporting the area. So I'm going to peel back some layers here and we're going to see the joint capsule next. So if I hide the middle glenohumeral ligament, I hide the inferior glenohumeral ligament, and then the superior glenohumeral ligament, you can see the structure in green is going to be our synovial membrane of the shoulder joint, which is our joint capsule. And that runs broadly from the scapula over to the humerus, all the way around anterior, superior, inferior, posterior. And that provides a layer of stability for the shoulder joint when you move. Now, we don't want to rely on this alone because it's a thin layer of connective tissue. So that's where all the other ligaments and the musculature really help support that. But it's nice to see sort of the anatomical picture of really what that looks like. If we hide the synovial membrane, you can see the glenoid labrum right there. So I'm going to isolate that structure. And you can see that the glenoid labrum here runs all the way around, and it provides, like I said earlier, it provides a suction cup effect for the shoulder. So it helps that with the joint capsule, they work together to provide some passive stability for the shoulder joint. Now, the bursa, the labrum, as you can see here, and then the synovial membrane or the joint capsule, those all have sensory innervation that goes back through the suprascapular nerve and the axillary nerve as sensory input. And that all goes back to through the C5, C6 nerve root. So again, whenever something's happening in these structures, I want to see what's happening at C5, C6, and I want to check out what's happening through their thoracic outlet area to make sure that it's getting proper input, that the signals are allowed to get peripherally from that tissue, the labral tissue, the joint capsule tissue, to more centrally at C5, C6. But it's really, in my opinion, it's really helpful to see sort of the breadth of which this take, how much room these things take up, and how the layers of it, so they need to work together. All right, let's go back to the screen here. So I'm going to stop this share, and then we're going to go back to our mind map. So we've covered the passive stability side of this. We've talked about the skeletal tissue, which really doesn't have a ton of innervation, but the more soft tissue that provides innervation and gives you some sensory input to that. Now, that is inert structure. It's not moving. It can shorten a little bit based on our postures, but we can't really directly influence that. What I care more about then is the active stability. So how can we actively create tension around the shoulder joint to provide support and provide proper tension so that the soft tissue doesn't take on so much stress and strain? Because ultimately, if you're not overtraining or undertraining, so if your shoulder mechanics are balanced and you have a strong training program, then that soft tissue is not going to take on the strain by itself. It's sort of, I always view it as our muscular system is at the front line of guarding and protecting that soft tissue. And if you're recovering well and you're training well, that sort of stuff isn't going to, unless there's a direct trauma to the shoulder, it's not going to take on that strain by itself. Okay, so let's go. We're going to talk about the rotator cuff, and there's four main rotator cuff muscles, which I'm sure we've all heard or learned about: supraspinatus, infraspinatus, subscapularis, and the teres minor. And we're going to show the essential anatomy version of these. But with them, you can see, again, we have the C5, C6, C5, C6, C5, 7. So much of this goes peripherally from the 5-6 sensory input. Well, this is sensory and motor on these, back to the lower cervical spine. We're going to add all the connective tissue back on, and then we're going to start adding some layers of muscles on here. So when we talk about the rotator cuff, I'm going to show you from the backside here. We have first our supraspinatus muscle. Supraspinatus comes from the suprascapular nerve, C5, C6, and it helps with the initiation. All of these muscles function together. You can think about it, I mean, literally as a cuff where they wrap around the shoulder joint and they function together to provide that feed forward initiation of movement feedback. So these need to be strong to help position the shoulder. So then the bicep, the tricep, the lats, all the other muscles that attach around the shoulder, they can do what they need to do. So supraspinatus, infraspinatus, which is on the opposite side of the scapular spine. The supraspinatus helps initiate abduction and a little bit of external rotation. The infraspinatus is a powerful external rotator, so it helps initiate the movement to then pull the shoulder into external rotation. Teres minor has a similar function in external rotation. And then lastly, on the front side of the shoulder, we have the subscapularis. And the subscapularis internally rotates. So with this cuff of movement that helps stabilize the shoulder joint, we have muscle that really helps control rotation, and rotation is an extremely important joint for the shoulder. Again, subscapularis is an internal rotator. The infraspinatus and teres minor are external rotators, and then the supraspinatus goes across the top of the shoulder. And that's why, because of how the infraspinatus is sort of tucked under the acromial arch, people who have shoulder impingement syndrome, that area receives a lot of friction and rubbing if the muscles aren't balancing around the shoulder joint. So those muscles, those are the four main rotator cuff muscles. We see a lot of degeneration with those as people get older. I like to think that's really due to a lot of shoulder weakness that happens in people as they get older. They stop using their shoulders as much. The muscles around it become weak, and as a result, these deeper stabilizers start taking on a lot more stress and strain. Going back to our mind map, there's something throughout the body that allows things to work very effectively or synergistically, and those are force couples, where muscles work together or they work in tandem to allow for proper, bigger functions. And there's so many force couples that exist between the rotator cuff and our scapular muscles. And so next, I'm going to get into the function of the scapular muscles and showing you the anatomical overlay of those muscles. So some of those muscles are going to be our trapezius, serratus anterior, rhomboids, levator, and then I put other. And under that other category, we're talking about the latissimus dorsi. We're going to talk about our biceps and triceps. And those are muscles that don't have huge connection, or they don't, a massive part of their insertion isn't on the scapula, but there's interplay with that. And also the coracobrachialis on the front side of the shoulder. So we're going to go over each one of those in some detail next. Again, what I want you to see is all of these run peripherally back to the cervical spine with their neural input. So again, you cannot do a shoulder exam without relating it back to what's happening at the cervical spine. And then you could probably make a connection. We can't really talk about the cervical spine without having further connection down to what's happening in the thoracic spine in the core area as well. So going back to the Essential Anatomy app, we covered our 4 rotator cuff muscles. Already in this layer of muscle, you can see the long head of the tricep. If we isolate that, it has connection onto the lateral border of the clavicle. And so when we engage our serratus anterior and our traps, it helps posteriorly tip the scapula. Well, the long head of the tricep can be a contributor to help with that posterior tilt. If nothing else, as you're doing a tricep or an extension-based movement of the shoulder or of the elbow, if you're not fixed from the scapula, then you're going to see movement up here because of how the tricep attaches to it. Let's add a layer of muscle on. And then the first one I'm going to cover here is our levator scapulae. So you can see that the levator, if we isolate this muscle, it runs from the C1, C4 transverse process down to the superior medial border of the scapula. Because of that, when it activates, it's a downward rotator of the so it elevates the scapula, but it works with the rhomboids to downwardly rotate. So if I am trying to raise my arms all the way up overhead, we need upward rotation and protraction for that movement. And if I have too much tightness, or if the shoulder blade's not kind of in the right position, then the levator and the rhomboids are going to be pulling against that movement to restrict that full upward rotation. Now you say, well, that's not that important for Aunt Susie who doesn't lift overhead. That's okay. But if someone is really pushing something overhead where they need to use a lot of strength and they're not able to clear the scapula laterally, then the result of that is they don't get up all the way, and then that pinches and creates subacromial impingement syndrome, or the deeper layer of that, you could think it could be some degenerative rotator cuff tears, extra strain on the joint capsule or the labrum. But this here is our levator scap. It goes back to primarily C3, C4 from a nerve innervation standpoint. So we talked about levator scap. I'm going to add, I think this is straightest posterior superior here. So I'm going to add another layer on, and this is our rhomboids, which work with the levator to, one, retract the shoulder blades together, but then also work as a potent downward rotation. So if I'm doing a row type of movement, I need to fix the scapular position with some rotator cuff and trap activation, but then the rhomboids help achieve the retracted position for that specific motion for rows, kind of like a bow and arrow type of action. So we have rhomboid minor, and then right below it, the rhomboid major, and those go from the thoracic spine connecting over onto the medial border of the scapula. Those two, you could think of them as a downward rotation. That rhomboid, levator, downward rotate. They have other subfunctions, but those work together to bring the shoulder blades towards the spine. On the opposite side of that, so those are some posterior muscles. Let me add on another layer. Actually, we'll go into it this way. I want to talk about our serratus anterior. And so the serratus anterior runs from the medial border onto ribs. God, I think it's, ribs 1 through 8 is where that attachment is. And you can see all those interdigitations onto the thoracic spine. So if you're trying to strengthen your serratus, but you're not strong through your core and through your rib cage muscles, you're not going to have an angle of pull for the serratus anterior. So in this function of the serratus anterior, it's known as the boxer's muscle. So as you throw an arm forward, you can kind of see those things turn on and light up because it helps with protraction of the shoulder upward rotation, and then a huge function of it is a posterior tilt. So if I need to raise my arms up overhead, but I'm weak in the serratus, I'm not going to get that full posteriorly tilting of the scapula, and that can again lead to shoulder impingement. And so this muscle here, you can see that's a pretty broad muscle, and it really helps control upward rotation and posteriorly tilting of the scapula. that muscle needs to work with our trapezius. Now, if you look at the anatomy textbooks, it's not going to outline upper trap, mid trap, and low trap. Different parts of the muscle are going to work differently, and that's really based on its position that it's functioning in. So the upper trap, which you could kind of draw a line from the lateral border of the scapula over to C7 roughly, everything above that in that quadrant, that triangle, is going to be the upper trap. So it's an upward rotator and it's an elevator of the scapula. Where I want the upper trap to be working is if I have to reach overhead and then push something up overhead. If you do that right now, you raise overhead and then you shrug a little bit, you can see how you can gain a little bit more clearance through the shoulder joint. And the function of that is if I'm doing a handstand type of movement, or again, having to reach something overhead, it's okay to have upper trap functioning in that overhead position. Where people often run into problems is as they are going to raise something up over, like just do a lateral raise, or if they have to reach out and grab something, if this is too, you could say, dominant in that position, then we're going to lose stability in the glenohumeral joint because the upper trap pulls that towards the neck. And the trap, because it attaches all along the cervical spine and the nuchal ligament, it then pulls from its spinal attachment throughout the cervical spine. So I have the upper trap, the middle trap, which is, you could say, this middle triangle part of the muscle from kind of through the thoracic spine, mid upper thoracic spine. It helps with retraction of the shoulder blades and tipping the shoulder posterior. And then the same thing with the lower trap, which is these fibers all the way down. The low trap, you could think about the upper and lower trap working together to help facilitate upward rotation. The low trap also is going to help anchor and stabilize. So if I reach my arms overhead, the ability to pull the shoulder blades down my back, that's going to be function of the lower trap there. So if I am holding something overhead, I can either use my upper trap here, or I can do the opposite of that and engage to the lower trap. Being able to do both of those is very important. So I'll look for relative weakness with someone and then strengthen that piece of it. But I want to really make sure that they can do both of them, because the reality of it is life is going to throw different things at them invariably through different situations. So to quickly be able to turn one on, or to have the total mobility in the shoulder to achieve either one, is what's most important. Let's go over anteriorly here. And so this is where we're getting into some of the other muscles that are attaching to the scapula. Or this one, the pec doesn't necessarily, this is the pec major here. That muscle is going to pull across the body, so it helps with adduction and internal rotation. And it's a very strong, powerful muscle that if you strengthen it too much, or if you're just stuck in a slouched position, it draws you forward, and you can see how that then pulls on the upper trap, and it changes the position of the head and neck. So if I'm too strong through here, or let's say not strong enough on the back, we're going to get this asymmetrical pull through the scapula that changes your glenohumeral mechanics. With the pec major, it doesn't directly connect onto the scapula, but it has connections over to the humerus, and it has connections onto the clavicle. So those attachment points, and it's a fan-shaped muscle. So if I am reaching up overhead, I'm stretching the lower fibers of it. If I reach into horizontal abduction, I'm stretching the medial part of it. Or if I get down into a low position, I'm going to stretch the upper portion of those fibers. And that's why when I do a pec stretch with someone, or pec mobility, I want to make sure that we're opening up that chest muscle in kind of various positions. So I'll often put somebody on a foam roller, making sure they're engaged through their core muscles, and then go through a full range of motion there so that they can handle a wide range, so that their pec muscle knows how to open up, shorten, and lengthen through a variety of positions. Pec major, if we hide that muscle or take away a layer, next you can see the pec minor muscle. The pec minor runs from the coracoid process to the third through fifth ribs. A minute ago, we talked about posteriorly tilting of the scapula, and that's going to be our serratus. Our traps will help with that. Our lats will help with that. But also then the opposite of that is going to be things that pull the shoulder forward. And the pec minor is one of the pec minor, some of the bicep muscles, and then also the coracobrachialis. Those muscles all tip it forward. So if I need to reach down and grab something, be strong there, that is going to help control those positions. On the back side of it is what posteriorly tilts. So the pec minor anteriorly tilts the scapula, and the antagonist muscles, you could say, are going to be your serratus anterior muscles that help with posteriorly tilting. Real quick, I want to show you the short head of the bicep, which comes up to the coracoid process. And then if we go right behind that, you can see the coracobrachialis muscle. Again, both of these, the main purpose, the main thing I want you to think about is that they attach onto the scapula. So we often think about these as being shoulder flexors, elbow flexors. But if you're doing those movements and you're not braced or stabilized by giving yourself some posteriorly tilt to start, those things are going to pull you forward, pull the body forward. So when I strengthen those muscles, or I'm strengthening these with people in the clinic, I'm making sure that the backside of the joint can stabilize the position. So I'm holding that into a neutral position as I work into those and work those muscles. Because if I'm not doing that, as I go to, let's say, do a bicep curl here, and I'm not resisting what's happening at the insertion point, I'm going to get pulled forward that way. And that just changes the mechanical advantage of that muscle. And as you're doing that, you're getting pulled into what would be a subacromial impingement sort of position. It's yes, you can get strong that way, but that's going to be the same position someone gets strong from sort of sitting at a desk for a long time, where they get pulled into this anteriorly tilted position. So let's go back to our mind map one more time. I'm going to stop the share. We have covered from the beginning what the skeletal structures that are important for the shoulder complex, the soft tissue structures, so our ligament, the joint capsule, the labrum, and the bursa. Then we talked about the rotator cuff, our supraspinatus, infraspinatus, subscapularis, and teres minor. And then we covered how those have to work with the scapular muscles, which is going to be the main ones that I think about are trapezius, serratus anterior, our rhomboids, levator scap, and then the lats, which I actually didn't show you, but the latissimus dorsi, the pec muscles, the biceps, and the triceps. Now, I think there's 17 muscles that attach onto the scapula, and we probably talked about 12 or 13 of them. Some of the other ones that do, they provide really like rib cage stability, and they help with breathing and expansion. Those are all very important for a well-rounded. So if you want to be a well-rounded athlete, or if you want to, I view all these muscles are very important for stability or mechanics of something. But these are the main ones that we train in the clinic. And by training those, we sort of broadly hit everything for a strong shoulder complex. Final takeaway points. We have active stabilizers or mobilizers, however you want to view them, and then we have passive stability. If you break them down into understanding them by the layers, you can see how they each support each other. You can see how each one of these things, from either a sensory or motor standpoint, all go back to the cervical spine through the brachial plexus. The take-home point of that is the position and the opening for the thoracic outlet is very important. So if you're doing things with your clients and you're really closed off in this area, it's going to be harder for the neural input to go from periphery more centrally, to get that input to tell you what's happening. So I think about things. I find that posture and biomechanics are important for the quality of input, and then understanding the anatomy and biomechanics then helps you do things from a better functional standpoint. So that is my fairly long overview on shoulder anatomy and biomechanics. I know I didn't cover specific ranges of motion that are required. We can post in the comments if you want to talk more about that. But by understanding these key concepts, it'll set you off on the right foot to working with clients that have problems with their shoulders, and also hopefully develop stronger shoulders for yourself. Because with me personally, doing things like side planks in the past, or even doing shoulder military press type of movements, used to often feel straining in my shoulder, not in the best musculature way. And once I figured out how all those pieces connect and how to really open up the shoulders and stabilize the scapula, then I started feeling the work happening kind of how it should through the shoulder joint. And that's where I got a lot stronger and more confident with my push-ups, with my military press, even bench pressing type movements. So again, if you please like the video, if you found this to be helpful, add in the comments if you want to see more of a particular thing, put questions out there and I will answer each one of them as quick as I can. So thanks for watching. I hope you enjoyed the video.